Hey everybody, welcome to NeuroSignal's live stream webinar. I'm going to be hosting it. My name is Omar Khatib. I'm really happy to have you all here. We have a great speaker tonight, Dr. Cynthia Dickerson, who's going to be talking about a really important aspect of medicine, which is what happens when you bring new technology in. How does it influence and improve your workflow? So we're going to be talking about that with her, about a new pathway for PFO detection, specifically with robotic TCD. So let me bring her up on stage and we're going to sort of chum it up real quick while everybody joins. Dr. Dickerson, good to see. How are you doing today?
I'm doing great. It's been a great start to the day, and I'm looking forward to ending it on a very high note.
Absolutely. I mean, what better way to spend a Thursday than talking about PFO detection, right?
Absolutely. I'll take it on any day, but why not a Thursday? I am so excited about this topic.
Same here. And shout out to the great team over at NeuroSignal and Robert, who are doing a phenomenal job. Again, bringing fantastic technology to market that's going to really improve the lives of patients. And while we get things sort of going, we see the view count's going up. So we're live on YouTube, X, and of course LinkedIn. For those who are watching, no matter where you are, go ahead and comment what city you're watching from. We always like to see where everybody's coming in from. So Dr. Dickerson, where are you joining us from?
I'm joining from Lakewood, Colorado, just close to actually Red Rocks in Colorado, just off the foothills. So it's a beautiful place.
Fantastic. I'm joining in from SoCal, California, specifically right outside San Diego. So
Awesome.
perfect. Well, Dr. Dickerson, maybe a little bit of a quick intro on yourself, your background, like where'd you do your training, and then we'll kind of jump into the topic.
Absolutely. So I'm a Colorado native. I am so biased, but I love it here. It's such a beautiful state. I've done most of my training, undergraduate, medical school, and actually residency training. I went away for a year to Phoenix, Arizona to complete my vascular fellowship at Barrow Neurologic Institute and got second to none training. And that's actually where I was introduced to this technology with NeuroSignal and some fantastic providers out there. And it's really where I developed my passion. And then I'm back here now working as a neurohospitalist, and I'm actually the medical director of our stroke clinic. And I use this day in and day out and as my bread and butter. And it really just makes such a big difference in my workflow and also to these patients' lives.
Fantastic. Awesome. And we got some comments. We're going to do, we can't shout out everybody. We'll do a few of them. So of course, Alyssa joining from Jacksonville, CEO and founder, Dr. Robert Hamilton from Claremont. Hey, Robert, good to see you. We got Danielle from New York, Madeline over in New York as well. We got Dan Hatchney out of Los Angeles, Summer out of Jacksonville with Alyssa. Hey, Summer, thanks for joining. Dan Eagles out of Rancho Santa Margarita. And we have more people joining. So again, thank you all for joining again. It's a Thursday. It's the end of the day. We know you could be with your families and stuff. Some of you are with your families. So hope you enjoy this. So let's go ahead and let me take off the banner here and jump into it. And by the way, if you have a question, I'm going to leave this scrolling at the bottom. If you have a question for Dr. Dickerson, we're going to definitely jump into a live Q&A. Ask it, drop it in the comments. Either we're going to get to it in the live Q&A, or if for some reason you're watching this on demand, you can still leave a comment. We will go through it. And if Dr. Dickerson would like, she can follow up with you via email or somebody from the NeuroSignal team. So Dr. Dickerson, let me bring up your presentation. Fantastic. And the floor is yours.
Fantastic. Well, I'm just going to dive right in. I entitled this Lessons from a Stroke Neurologist. Again, these are things I see day in and day out. And I'm here just to advocate and present for how big of a difference having this amazing technology is on my workflow and on patient outcome. A lot of times it's helpful to see numbers, and I have a lot of numbers in here, but I'm honestly going to spend a good amount of time talking about stories because those really are the things that stick. And I think they really represent kind of a microcosm of what I see on a grander scale. So I'm going to start with this first case study. This is a 49-year-old female. I saw her actually in clinic just a few weeks ago. She initially had her first stroke in 2018. At that time, it was essentially cryptogenic. And for those of you not familiar with that term, we did not have a cause for it. And they chalked it up maybe to the fact that she had a history of hemiplegic migraines, but really didn't have a great cause and a great way to prevent strokes in the future. She was actually seen in a different hospital, but ended up in our hospital May of 2025. New embolic strokes, still unknown etiology. None of the studies initially done in the hospital really were able to come up with a cause, and no cause from her prior hospitalization. And you'll notice there's about a 7-year time gap between her first and second stroke. I'm going to jump into why that's significant. She was actually transferred from a hospital where they already did the transthoracic echocardiogram, which was negative completely for any bubbles, no shunting. And then also she got a TEE done in the hospital that was completely negative and did not show any shunting or evidence of a PFO. She followed up in our clinic, and of course we recommended her getting a robotic transcranial Doppler, which demonstrated a grade 1, which is a smaller end at rest, but with a Valsalva, she had a grade 4 PFO, and essentially on a grading scale at 1 to 5, that's second to the largest degree of a shunt that we would be able to find. Initially, the cardiologist was super hesitant to close this patient, but I advocated and was persistent. And I just got a text about a week ago that this patient's PFO was closed. And we have now successfully identified an etiology for stroke and given her a preventable measure that data highly supports, helps prevent these strokes in a significant way moving forward. This is actually what her data look like. You can see the TEE, which is the transesophageal report here, that both with Valsalva and rest, there was absolutely no shunt. And then I just have a snapshot of her bubble study here that shows a very significant shunt. So just to review some data, essentially, we have well-established data now that when we compare transcranial Doppler to transthoracic echocardiogram, which is over the chest, transthoracic is always going to have a place in cryptogenic stroke. We still need to look at the structure of the heart. But as far as visualizing the bubble portion of it, there is just a lot that is missed. It's widely available, but it's very limited as far as that window. You're kind of trying to go in between ribs, and you just miss a lot of the data as far as the bubble study. TEE is a gold standard study, or at least it has been. We are pushing the front line as far as making TCD that gold standard, but it is better visualization. You actually have the camera down the throat looking at the heart without that rib window. However, not only is this invasive, and not only is the patient going through a procedure, they are under light sedation. They are not able to adequately participate in what I think is sometimes the most important aspect of the study, which is that Valsalva, where they're bearing down. And really sometimes that revealed, like in this patient, the most significant portion of the shunt is when they do that Valsalva. And it's limited because of the sedation during that study. Handheld TCD is another modality, of course. Same technology as far as what it is looking for, but does not have that robotic portion. It does have high sensitivity for PFO, but it's operator dependent. It really depends on a tech who knows what they're doing. And sometimes it has disadvantages. It's not actually looking at the heart, can't see between a pulmonary shunt and cardiac shunt, but obviously is detecting those patients are not sedated. And so there's an advantage there of getting some of that more high yield information. This was a study done as far as comparing TCD to transthoracic, which is over the chest. And as you can see, sensitivity and specificity hugely outweighed when it comes to the transcranial Doppler. A huge amount of studies are missing patients who leave the hospital thinking they don't have this shunt, and it's really because they didn't get the adequate study. This was the bubble trial that was Neurosignal essentially testing this, really looking at how many shunts do we miss when we compare the transthoracic echo with the robotic TCD, and the answer was up to 2/3. A majority of these shunts are being missed, and especially these young strokes where we are trying to figure out, we have no other reason for it, we are missing these shunts in these patients. And one of what is considered a standard of care is really falling short there. So this is just kind of an overview of literature that is continuing to compile, starting with the bubble study in 2023 and building, that is just adding to this level of evidence. The American Heart Association, the American Academy of Neurology, multiple large hospital systems are all backing the fact that we are missing too many of these shunts. Too many patients are not getting the adequate information they deserve based on these transthoracics alone. And even some of these esophageal echocardioms are falling short. And I think I really highlighted in this patient case where even the gold standard TEE missed this shunt that was able to be closed. And I will tell you, this is not a one-off in my world. I see this more often than I think it should be the case. So I'm going to jump into another case. This is a 30-year-old 14-week pregnant female, initially presented. Again, this was to an outside hospital. She only had numbness at that point. She got some imaging. It was normal, so she was just discharged home. 2 days later, came back, was having worsening symptoms. And we did some additional workup and ultimately found what looked like an embolic appearing or a clot-like related stroke. Still cryptogenic at that time. We did a thoracic echo on the chest, which was negative. A traditional TCD, which is actually, the non-robotic, was also performed. And it actually did show a shunt, but a pretty insignificant one. It was a grade 1 at rest and with Valsalva, which is, of course, it's there. But as a provider, as a clinician, I'm always wondering, benefit outweigh risk. I tend to not aggressively close and do surgical management of these smaller shunts. And so really it was kind of there, but probably not significant. TEE actually could not be done at that time or was deferred because she was pregnant, and the thought of sedation, putting her under, and more of an invasive procedure was not thought to be the right thing to do at that time. So we ended up getting a repeat robotic TCD. And as you can see in this photo here, significantly different results here with a grade 0 at rest, which is, kind of was seen earlier that we didn't see a whole lot on rest, but again, on that Valsalva portion, increased to a grade 4. And I took a snapshot here because this is a very significant shunt that as a clinician, I am much more likely to blame the CCD. And I actually did send her for closure after her delivery, and she is doing very well now. So this is just bringing up the point, even when it comes to the technology of TCD, there is a difference between manual and this automated robotic technology that Neurosignal has available. TCD manual, and I actually do these myself. I perform these manual exams. I just did one yesterday, in fact, can be very technically challenging, both based off of anatomy and a patient really sitting still, having to hold it there very still. It can be difficult. You really have to have a specialist, a good team, and that's just not as widely available as this test should be, and able to give patients the care that they deserve. So the benefit of having this robotic technology is that the patient's head is actually braced so that it really helps increase the quality. The signal is held, it's locked in. It uses AI technology to identify the artery. And it is very consistent across provider, no matter who is doing the study themselves. I wanted to go back to this bubble trial and emphasize this point at the bottom, which I have highlighted, that the robotic NG2 outperformed traditional TCD. And again, I advocate for TCD all the way, but even when it was compared to manual TCD, it outperformed by 2 times. Of detection. And I would advocate that probably the size of shunt is different as well when you compare manual to this robotic TCD. Not only is the technology phenomenal, but Neurosignal really has this entire system with it. Interestingly, at my institution, and I'm going to get into this in just a little bit, I help perform these studies, but we actually utilize EEG techs, which have 0 ultrasound training. A lot of institutions use specifically trained ultrasound techs, maybe they're echocardiogram techs, but we are actually using techs that have 0 ultrasound training. And they are able to pick up on and do these studies adequately just because of the ease of technology. There's also this dedication to customer success. We have had Neurosignal come out multiple times to our institution, help with training, help with onboarding. guidance in between studies. They are helping us manage. If we're having IT issues, they are either on the phone, they are there in person helping us manage this. And this really makes it possible for us to use different departments in our hospital to make sure we're getting as many tests done as possible. There's ongoing education that's available for our techs. Again, getting as many people onboarding as possible, and it's always available so that we can continue to expand our initiative as we're looking to onboard techs that are available. And then, of course, just the service and support. And this has made a huge difference in our hospital, being able to navigate some of these challenges and kind of differences in how we're utilizing it in an outpatient setting, to be able to navigate that and create a workflow. So this is actually the workflow that I have developed. I am, again, the medical director of our stroke clinic. And so I actually, from the ground, created this workflow and protocol so that patients who are not getting the study done in the hospital or coming to us afterward can still get this study done and get the answers they deserve. So essentially, we have patients. Our team is staffing hospitals all around the Denver metro area. We are identifying these patients that are young, cryptogenic, people that we think are high yield to find something like a PFO, and that surgical management may make a difference in their care. We're identifying those, and then we take a special effort to note whether they get that TCD done inpatient, and if they don't, we kind of have that noted. And we are actually able to schedule them prior to their clinic visit to get that TCD done. The reason it makes a big difference for me, and I'm going to emphasize this in a moment, is that knowing their PFO status when they roll into clinic, I already can go on to the next step. I can either say no PFO and I'm going down a different arm of the cryptogenic workflow, or I can say I have the PFO and then I get to expedite getting what they need and recommending things like closure. So we often already have their PFO status either from inpatient or outpatient study by the time they roll into our clinic. Day of, we're able to get their hypercoagulable workup. And a lot of this, all of our major trials that recommended PFO closure still did have a criteria as far as ruling out other etiologies like hypercoagulability and arrhythmia. So in the meantime, we're able to get their blood drawn for hypercoagulable studies. We're able to get a cardiac monitor. And then by the time we have that information, our clinic is really proud that we have a median discharge to closure recommendation of 45 days. It's actually, this says discharge to closure. It's actually discharge to recommendation of closure. And the reason there's that difference is that there are some delays on the cardiology end as far as scheduling it. But as far as this patient having a neurology thumbs up, which insurance needs to get this done, that is done within 45 days, reduces their risk of being lost to follow-up recurrent stroke. And we're really able to get them going and get the cardiologist everything they need to get that patient scheduled and taken care of, and doing better and recovering and back to their life. This last case study is a gentleman, again, very young individuals that we're seeing here with stroke, a 39-year-old male. He initially presented out of state to Nebraska. There, his workup was done. They found a thalamic stroke that was on the larger end, looked embolic. So we're looking for these kind of clot-related strokes. They did, again, a transthoracic echo. Small amount of bubbles were seen there. So there was already this idea, probably a PFO. But he was transferred to our facility to do more workup. Again, if this patient would have discharged to the hospital, a small amount of bubbles, a provider might see that, and 25% of individuals are walking around with a PFO, and they might have thought, probably incidental. I myself may not have done much with that. If I really thought it was a small shunt, I may not have gone down that route, but they came to our institution, were able to get a TCD. And it demonstrated, again, this large shunt, grade 2 with rest, grade 4 with Valsalva. They were able to get the TEE performed at that time, which confirmed the presence of that PFO. This patient, and at our hospital, we get a lot of Ketchman patients from other states. This is often the cause. They come to us out of state, and then they go back to their home state to get additional workup. He went back to Nebraska. And then a few weeks later reached out and said, I can't get a neurologist in the community. I can't see a cardiologist fast enough. what can I do to get my PFO closed now that I know about it? And so I emphasize here that this is a huge gap nationwide. Not only is there a limited number of neurologists as it stands, but the amount of vascular stroke trained neurologists who are trained to advocate and have up-to-date literature like this, these major trials that came out in the last 6 to 7 years, they are hugely lacking in the community because they're all in the hospital. So the point I like to drive home in this case is that this patient was now aware, educated in the hospital. They had a note from the hospital saying, by a neurologist, no other identifiable cause, a plan to say if hypercoagulable workup is negative, if the cardiac monitor is negative, I would recommend closure. That already reduces their need to see a neurologist before they get closure. Of course, we want them to be established, but it is one less barrier to them getting what they need, seeing a cardiologist and being able to get it done, because that gap is so huge. This is kind of our workflow as far as getting TCDs done in the hospital. And I am a huge advocate of getting them done as quickly as possible. Again, we make these available outpatient, and I think patients deserve that. Patients deserve to get the study either way. But as a clinician, the reason this makes such a difference in the hospital is that I am already informed of someone's status. And in my mind, I am already able to go down one track or the other. Is a shunt involved at all? Or if not, it's going to cause me to go down a different path. And it really helps me expedite this patient's care, get them the tests they need, and really get them sent to the right place quicker. So this is kind of our algorithm as far as in the hospital. So we initially identify patients, inpatient or OBS in the ER, that are stroke TIA symptoms. As best we can, we get CTAs in the ER, we get those quick. We try and get a brain MRI to confirm stroke, although high suspicion for TIA is also a reason we trigger getting these tests done. We do have a threshold for less than 65, and a lot of that is because the literature as far as PFO closure supports individuals actually younger than 60. We do advocate for those patients who are kind of on the cusp, so we include those who are under 65. And then we end up getting an echo, but as best we can, we try and reduce the need for the bubble study on the echo. Again, there is huge need for the echo itself as far as structural information, but the bubble portion we actually attach to the TCD study itself. Of course, we get standard workup like telemetry, stroke labs, but then we get their TCD with the bubble portion. If for some reason they're unable to get it done, that's when we can kind of trigger a limited portion of the echo with bubble. But again, we have such a high rate of successfully detecting these and getting the study done that that's usually not an issue that we depend on the echo with bubble. That's uploaded. The neurologist actually reads it at our institution, puts it in the EMR, and usually by the time the patient is leaving the hospital, we are able to identify whether they have that. If they have a 1 to 2, again, clinically on that end, we're still digging for other etiology. Anything Spencer grade 3 to 5, we are really going down that route of getting more testing and trying to identify as many tests in the hospital that we can send that patient out with to be confident that we are sending them in the right direction, which is probably closure. And then, of course, sometimes we have to get some of these outpatient studies. The transesophageal doesn't always get done in the hospital. Sometimes they do need cardiac monitoring and seeing someone in a clinic. And again, we help kind of expedite that. So this is just a short overview of the numbers from our institution since implementing. This shows November 2024. We actually have had NeuroSignal earlier than that. This is just our last year. Over almost 1,000 exams that we've been able to perform, and almost half of those, 441, have detected a PFO, and is giving these patients information about a potential cause of stroke that, again, is making a huge difference. And if you note that green portion on the top, these are large PFOs that, again, are making life-changing differences as far as reducing young individuals' cause for their unidentified stroke. So without further ado, I'm going to end there and make plenty of room for questions. I could go on and on with so many cases. It was really hard actually for me to limit it to 3 cases because I have so many that I have seen. These are not one-off. These are not the minority. I see these often, and it truly makes a life-saving difference. And I get to interact with these patients. That first patient who got her PFO closed was in tears saying no one else found the cause. And I wanted to highlight actually from that case, all of these large PFO trials were only 5-year follow-up. Again, she presented at the 7-year mark. These patients were not included in the data as far as what if they show up with a stroke beyond that 5 years? We haven't even identified a larger population of patients who are having stroke down the line who do not have an identifiable cause, who are now having recurrent stroke because we have not identified and advocated for the right type of treatment. So this makes a huge difference on inpatient, outpatient workflow. I'm a huge advocate, and I would love to welcome questions and any discussion on this robotic technology that is, I think, the gold standard future of cryptogenic stroke.
Awesome. Dr. Dearson, thank you for that. So let's jump straight into the questions. So we'll kind of kick it off actually. So Eric has a question, which is from a workflow perspective.
Yeah.
Your thoughts on the difference in referral for a small shunt 1 to 2 versus a large 3 to 5?
It's a great question, and I often question this myself. It really has to do with, do I have any other factors, any other kind of road that I'm going down? I have actually advocated on a few occasions, either usually not smaller than a Spencer grade 2, but if I have no reason for this patient having stroke, and I have done extensive workup and even done a cardiac monitor that's implantable, I will usually give them about 6 months, maybe a year, if we have not detected anything, or if they're super young and something like an arrhythmia is really not at the top of my list. The encouraging news about these large trials, that even small shunts benefited from PFO closure. They did not benefit as much as some of these high risk shunts, as in grade 3 to 5 or with an atrial septal aneurysm, but they still benefited when compared to antiplatelet medical management. And so I really advocate, maybe, it's not the end game. Maybe we still keep looking. Maybe you have a loop recorder, an implantable monitor, but I am still going to advocate for closure because I have data to support closure of small shunts still makes a clinical difference.
Got it. Joshua asked, from an age perspective, your thoughts on closure recommendations. We know guides are at less than 60, considerations for slightly older.
Yes. So I have a lot of partners, and we all tend to agree 60, it's not an arbitrary number. There actually is some data about with kind of larger number of PFO closures, although these are older studies with older technology, that there is slightly higher risk of periprocedural atrial fibrillation complications. However, these patients were not included in the trials that were positive. And so it's an unknown. It's not necessarily they didn't benefit. It's that they weren't included so that we have the data. And a lot of us advocate that within this less than 60, we're talking about young, healthy individuals without other medical issues. And some of those patients are 70 and in that same category. They are young, they are active, they have no medical issues, and their periprocedural risk factors are very low. And so to me, it really depends on other risk factors. It's not all an age thing. I have 70-year-olds that are healthier than 30-year-olds I've seen just based on their risk factors. And so I really advocate, and a huge part of this is collaboration with cardiology. If they feel confident, if they feel like risks are still fairly low, the cardiologists of closing the PFO and they're willing, I advocate for these patients even up to, I think I've advocated for a 72-year-old with no other cause, multiple strokes without etiology, and a monitor in place that we didn't find it. I really push that boundary, and I think it's the right thing to do.
Got it. And then, so here's this came outside of the chat, but from like a workflow perspective, and actually I'm going to combine questions. So we have one is Madeline asked the question, which is who owns ordering the exams in your institution, and then the other question is like from a workflow perspective, who's involved in the decision making process. So maybe you can sort of talk about both those things.
Yeah, it's a great question, and it's a little bit multifactorial. So at our institution, our neurologists are a consult service. At some institutions, they are a primary service, as in they own the patient from, the second they get admitted to the hospital. We're a consult service, so there's always a medicine team on board. They're in charge of their admission orders, their discharge. And so typically the admitting provider kind of initiates the stroke order set, which has the TCD study in it. However, we are always overlooking, and we have a great team of stroke nurse practitioners that are always looking out for this category. And so we kind of have two eyes on it. Again, the hospital's medicine team is kind of aware to click that box if they are essentially admitted with a TIA stroke diagnosis and they're less than 65. We always overlook that, and our stroke NPs are also looking and making sure the test is ordered. And so we own it in the sense that either if we think it needs to be canceled and we say, you know what, I really don't think this was stroke TIA, and it was ordered, but we think it can be canceled, we own that. If it was not ordered on the initial order set and we think it should, we own that. But it also is on an order set that our medicine team can be a part of. And then as far as getting our outpatient studies, we definitely own that, because the medicine team just does not know who didn't get it done. They're not always aware of the results. Sometimes the report itself doesn't come in by the time they're discharged. And so we're really looking over, skimming, making sure they got the test done. And if they didn't, they get it outpatient. And that really ensures the right type of patient gets the study done.
So kind of a follow on to that is, can you talk about a little bit of the differences in terms of the workflow for, let's say, inpatient versus outpatient?
Yeah. So again, inpatient, there's a lot going on, and the unfortunate reality, we have a great workflow, but as far as whether it works 100% of the time, in reality, it doesn't. And a lot of that has to do with these young strokes, especially not severe strokes, are in and out of the hospital in 2 to 3 days. So they do need a structural echocardiogram, which oftentimes is prioritized. And if they are ready to roll, and for some reason they are over the weekend, it's the evening, they haven't gotten their TCD study done, it's not always working out the way that we'd like as far as order of events. And so we depend on having this workflow that is very helpful, but we realize delaying discharge, a patient sticking around for a whole other day on a Sunday to go to a Monday to get the TCD done just doesn't work. And so it really is guaranteeing that these patients get the study they deserved, irregardless of whether it is available that moment in the hospital. And so we really rely on having both of these workflows available to get patients studies they need.
Got it. So we have another question. So Alyssa's asking is, can you speak to the importance of moving a patient from cryptogenic to a known etiology for the patient, the hospital, etc.?
Yes, I'm so glad you brought this up, Alyssa. I will tell you the amount of patients who sit in front of me in either category. Either we do not have a cause from stroke, and we have gone down every road, and they don't have a PFO, and they're saying, so you're telling me I don't have a cause for stroke and I am just living my life unknown if I'm going to have another stroke, unknown cause. It is devastating as a provider to deliver that news. And so to find a PFO, and not only that, but to know that I can recommend a fairly low risk procedure to effectively reduce their risk for future stroke. And again, I think there's so much data about maybe how much in a lifetime we're reducing stroke. These studies are only 5-year follow-up. What about these young 30-year-olds who have have 20, 30, 40 years to live, and that we are reducing stroke over the entirety of their lifetime? I have patients in tears saying, thank you so much for finding a cause. Thank you for recommending a tangible treatment that we now have strong data to say it is superior in reducing stroke over the standard of care with antiplatelet therapy. And it makes a world of difference anxiety-wise, and just knowing, rest assured, that we get to come to their cause of stroke, and that we feel like really literature supports that. So huge difference.
What about, can you talk a little bit more about like what additional steps are needed if, let's say, TTE and TEE are negative, but the TCD is positive?
Yes, that's a great question. And actually, the American Heart Association put out a great review article just last year in 2024 that talks about some other studies that help identify not only the PFO itself, but also high-risk PFOs. I personally have advocated and really pushed and kind of have my own literature to support, hey, I've identified this. TCD is so sensitive and specific. This is not an aberrant finding. We can't, randomly produce these bubbles without a shunt there. Sometimes, again, we do look for a pulmonary shunt, and so I'll make sure that we're not looking for a shunt somewhere else. So I will advocate strongly, but there are other studies like cardiac MRIs, cardiac CTs, ICE studies that essentially are an additional piece of information that can help identify a PFO when it wasn't found on the TEE. And a big part of that, in addition to the patient not being able to Valsalva during a TEE, the provider is supposed to do a hands-on Valsalva to the patient, but that's not always done. And so sometimes I'll advocate, repeat the TEE, really push, really get as best Valsalva ever as you can. But I will tell you, recently, I have recommended multiple cardiologists have been on board with this, that they will go for the closure and essentially go with the catheter and attempt to go through the PFO, and it's successful. And again, if I'm really able to advocate and present from a neurologic perspective that I can confirm my tests demonstrate the PFO is there, they will go for closure and assume it's there. And every time that I have recommended this, it's been successful, which is encouraging.
Got it. Yeah. And sorry, earlier I was looking down. We have this one screen up here. We have the phone, so we're getting questions from all over the place. We're going to try and get to everybody. So Luke has this question, which is ES-US percentage remains really high. How big of an impact on this percentage could be attained simply by using TCD versus TTE as the screening standard?
I mean, I would love to see those numbers, but my answer is a huge difference. And actually, we are actively working in our stroke clinic to quantify this. As we know, up to 30% of patients leave the hospital with cryptogenic as their etiology of stroke, as in we do not have an identifiable cause. 30%, that's a third of patients coming in with these embolic looking strokes. And so in our clinic, we are significantly able to reduce that. We identify a huge number of PFOs that were not identified in the hospital. We're able to give them closure. And so I would love to see these studies. We are actively working on gathering our own data from our clinic. But the answer is a significant amount. And if we go back to the real bubble study where it confirmed, in this specific context, and now in multiple institutions around the country, there is a significant large majority, if not 50% of shunts that are being missed on standard therapy. Not every neurologist recommends a TEE in the hospital, especially if they don't have any reason and they don't see a PFO on the transthoracic. And so we are missing a huge portion of these without getting more in-depth testing. And again, a very non-invasive form of that. And so the answer, if you were to peg me down, is I bet we could half that number of cryptogenic strokes just by increasing our identification of PFOs with transcranial Doppler.
And it makes sense too, because once a patient's there in the hospital, some of these very simple interventions just to gather more data is so important. Yeah. And I think that's really key for a lot of, I think, frontline medical technology, which is if the patient is there, you might as well do the testing that you need to, because the chance that they're going to come back is very, very low. And the next time they come back, it might be much, much worse. So I feel especially in this advent of let's say AI and data, one of the big keys is how do you make sure that you capture really high quality data at the right time? And so I think if the patient's there and you can do this, you might as well do it.
Absolutely. And again, at our institution, and every hospital is different. Not only are we missing out on some of these patients that get sent to our institution for out of state that we really can't manage their care ongoing, but we, prior to us having TCD available in the hospital, we were missing these patients in our own community because they go to a community neurologist and the information they have from the hospital is they got a TCD or they got a transthoracic echo. It was negative. They're a young patient. They are not even all aware of this new literature because it changes so quick. And these outpatient providers who are kind of generally managing a lot of different patient populations within neurology are not triggered to look for these patients, to look farther, to know about TCD. In fact, I will admit, and I won't use names, a provider who I know who's actually vascular stroke trained, but spends a majority of his time in the community does not know this literature and is not recommending TCD for his patients. And it just makes me think, if this is a stroke specialist that is missing out on this because they are not staying as up to date on literature as some of our colleagues, just because of it's kind of in our face day in and day out, how many non-stroke trained non-specialized providers are out there missing this when they're kind of handed the data. We didn't see the PFO. And even if I see the PFO, what do I do with it? Especially if it's the small shunt, is that significant? And so for a patient to leave the hospital, not only with the information, but a vascular neurohospitalist trained recommendation in hand to say, if this and this, then do this, it makes a huge difference on the patient getting what they need as quickly as possible.
Yeah, it makes complete sense. And by the way, on a little bit going back to a technical topic. So Michael asks, how often do you need to deviate from the established algorithm due to operational limitations and resourcing? Any successful mitigations you've implemented?
Great question, Michael. This is kind of an ongoing thing that we're navigating at our hospital. I would say there's two major limitations kind of in my experience as far as patients who either don't get their TCD done or it's delayed during their hospitalization. One of those is we try and get TCD early on in the hospitalization, have that information. And again, sometimes we trigger getting some of these other studies afterward.
When is Abby coming?
In a little bit. This is my daughter who just wanted to come in and say hello.
I love it. Hey, I love it. I love it.
We talk about brain. What are you going to say?
We have a little baby who's right in our living room.
That's right. We have a baby sister.
Oh,
we talk about brain health a lot in our household. And so even my daughter knows about things like this and how to support brain health and reduce stress. All right. Head on out with daddy. As far as that algorithm, Michael, that you were asking about, some of the limitations. So these patients are coming in with strokes. Some of these young individuals are doing really well. They're discharged quickly, but some individuals are coming in with quite disabling stroke symptoms, and they're not even able to tolerate the test, not because we don't have the kind of improved head device that makes it an adequate study, but they are just too medically ill to get the study done. And then kind of throughout the course of their hospitalization, the techs are always checking in saying, when can we get the study done? When can we get it done? But kind of throughout the delay of their course, circling back around and finding an appropriate time when these aphasic patients that don't know what's going on, getting the study done. There's some technicalities like that that we see in stroke that limit the study, but that's going to be all studies all around, including a transthoracic echo. So that's something that we're a little bit limited on, but we as a neurology team that's following the patient, we really try and follow and make sure by the time they get discharged, we do circle back around to that. And then the other one is there is a reality to a majority of these echocardiograms are now being done with DEFINITY contrast. And it actually is a reason for false positive findings on the transcranial Doppler. Essentially, that contrast sticks around in the heart and it can demonstrate a falsely positive bubble study. And so we do have to wait a certain amount of time for that to wash out of the system. And so let's say they just got their echo done and they were able to get it done quickly because we're really pushing for that as a metric to leave the hospital. We then have to wait 12 plus hours and they might be ready for discharge and the hospital is kind of pushing for them to get out. So those are some of our limitations. We are often pushing for TCD to be done first before echo, so we're not running into that contrast issue. And then again, as soon as they can tolerate it, we are trying to get that study done, and we are trying to really be aware if it hasn't been done that we're triggering the ultrasound team. I know the order was placed 20 days ago and the patient's been here forever, but please circle back around. Please make sure it's done. We really like that information. And so some limitations, challenges there, but as much as we can be aware of it as a neurology team and advocate for it, we're working to overcome those.
Got it. And we have one question that came in that's it's like a paragraph long, but I'm going to kind of summarize here. So essentially the theme here is that TCD has an important role to play as a diagnostic tool beyond just, let's say, finding closable PFOs, which it does. The question is, what other uses of TCD are there in stroke?
My goodness, I could spend an entire hour talking about this. So I'm going to limit
That's the
it to
next
actually
webinar.
exactly. The next webinar is all the uses of TCD that I am such an advocate for that I think many individuals don't know. I have a perfect case I literally encountered a week and a half ago. So this individual came in with a cryptogenic embolic stroke. I think she was 35. And by the time we left the hospital, didn't have any identifiable cause, including TCD bubble that was negative. So no PFO, no identifiable cause. Even her vascular imaging was quote unquote normal. And essentially, this patient had the type of stroke that we as neurologists identify as watershed, as in there should be a vascular abnormality there. Something looks like an artery was narrowed, didn't get enough blood, and it's in one territory, but we didn't find it on any tests that we looked for. I screen all these patients because I'm the medical director of our stroke clinic, and I make sure we get all the tests they need done before they end up in the clinic. Interestingly, I personally reviewed the TCD, which the report is normal because there's no bubble. Her velocities were elevated. So not only is TCD looking for the presence of bubbles, but it is telling you a lot about the blood vessels. It's telling you about the velocity. It's telling you about intracranial resistance, a lot more information that can help you identify cause for stroke. Her velocity was 2 times the upper limit of normal, and it showed up on no other test in the hospital. And so I was able to go back, kind of review her imaging. It made sense with actually her cause of stroke. And I actually think the patient discharged. I actually reached out to her just the other day to try and close that loop. And I'm still waiting for her to get back to me. But essentially, I am now able to go down a whole new route of stroke cause and potential treatment that she missed out in the hospital, because this study gave me more information about her vessels than the standard of care, which was the CT angiogram. And I think she even got an MRI with contrast, and none of it demonstrated any vascular abnormality there.
Interesting. Let me see if we got any more questions. I think we covered all of it.
I answered every
actually,
question there
I
is.
think I got.
Great.
You know what? We got one last one. You got one more. You got
I
one more.
do. I could go all day. Yeah.
I don't think we covered this one. So Summer asked, "What are your thoughts on post-closure TCD testing?"
That is a great question. And actually,
aren't you happy we made sure we didn't miss that one?
I am so glad, Summer. Thanks for bringing this up, because I didn't bring it up in my presentation. I think it's a huge area for TCD. So far, we have been looking to integrate actually our workflow as far as outpatient TCD studies just became up and running as of February of this year. And so we're even navigating how to get these done, how to standardize it. I really think these post-closure TCD should be a standard within the closure cardiology guidelines. A repeat echocardiogram, which again is transthoracic and limited as far as a bubble study, is the standard as far as affirming that the PFO was closed adequately. And as we know, it's missing a bunch of shunts. So let's say the PFO was technically closed. They repeat an echo. It looks like the device is there. The bubble study is negative. What if it is missing a small shunt that they can't detect there? And so I think there's a huge need for TCD to reassure the patients the hole was closed adequately. The ways I've utilized it so far, and again, I think there's so much more use for it and so many more ways I would like to advocate for it, is patients who come in with recurrent stroke after a PFO closure, that they didn't have any other cause of stroke. We closed their PFO and they came in with a new stroke. I have now added TCD as an extra modality. Yes, we closed it, but was it closed adequately? And is there a possibility that even the surgical procedure, even though it's obviously recommended and for the most part has very low complications and post-closure issues, it does happen, and we can then advocate for them getting the care they need that may have been missed on another study, which would again been a standard of care transthoracic echo. So I think it has a huge area for adding to that standardized follow-up care. I think it also is so reassuring to the patient to go from a Spencer grade 5 and then we do it again and it is a completely quiet 0 out of 0. It reassures them the study was done adequately. If we're ever in question in the future, is there any issue with it, we can be confident. And we also have a apples to apples comparison. We did a TCD prior, we did a TCD afterward, and it kind of confirms either the continuation of an issue or the absence of an issue, so we can go down a different path if we need it. So great question. Should be more of a standard. I would love to advocate it more. We're not quite there yet, but I think it really should be a standard for follow-up on these patients.
Love it. Awesome. Dr. Dickerson, look, thank you so much for spending some time with us this evening away from your family and everything. And I want to thank the audience for joining. If you have any more questions, again, if you're watching this on recording, go ahead and drop your comments below and we'll be able to follow up with you. So thank you all for joining. If you enjoyed this, forward this on to a clinician that you know, and be sure to follow the Neurosignal page for like more content like this. We recently released a really nice newsletter called Inside the Signal that just brings you cases. So be sure to check that out as well. All right, everybody, take care.
Thanks.